Hello, everyone. Welcome to yet another Thursday VMR. I'm very, very excited to welcome all of you to an all-internal CP Solvers affair. I think today we might start with the people who are anchoring this wonderful effort. First, with Naureen, who is doing scribing. I think you might be suffering from Naureen withdrawal because it's been a few days since you've heard her voice. So, update us a little bit on how you're doing, how life is treating you, and uh, yeah, take it away.
Hi everyone, I'm Naren. I'm an IMG and I am currently looking forward to do a lot of shoveling because there's a
Oh
storm
yeah.
here in Toronto.
Oh man.
And I've been doing okay, just surviving, living. Yeah.
Mhm.
How are you guys?
How do you feel about the snow?
Um, it's really pretty to look at. I
Yeah.
gotta give it like
Yeah.
credit for that. It's beautiful, but really hard on the back. So
Oh
yeah.
yeah. It's a good way of seeing it. Yeah,
Yeah.
for me it's great on the eyes and horrible on everything else. So that's why I think in sum total probably a net negative. But Parisa will disagree. Sure. She's made many snow people recently, I've heard or will do. So that's awesome. Thank you so much for being here and for describing. Rahul is doing the teaching points today. Rahul, I imagine that you've never seen snow in where you are in the world. Is that right?
No, not really. I saw the snow in Connecticut while I was doing my
Yeah.
rotation in Portugal. Yeah, that was
Yeah.
the first time I
What
witnessed the
was
snow. But I really liked it.
did you?
And yes, I was walking, even it was minus 10 degrees, and I was wearing my glove. It was really
Yeah.
cool.
Amazing.
I
So
really loved
your hands and your feet don't get much of a vote in your overall body perception, I imagine, huh? They're grossly underrepresented. Okay, all right. Fair enough.
it.
Fair enough.
Everything, the snow and everything. I used to write all my friends' names and everything on the snow. And I used to take a pictures. And it's,
Really? Oh my gosh, that's amazing. That's
yeah.
amazing. Well, hey, thank you so much for your positive energy. Very, very excited for all the learning that you're gonna summarize at the end today. Today, I'm very, very grateful to, in terms of the sharing the stage, I'm very, very grateful to share the stage with Mariana, who does not need an introduction. She's been part of CP Solvers for too long to count now, and has slowly but surely risen her way to be a leader in our space. And I think there are, many different kinds of leaders, but Mariana is the kind of person who will gently and quietly get things done with such incredible quality. And the thing that strikes me most about her is just how effective she is in so many ways, coupled with how deliberate, kind, um, and thoughtful she is. There are a lot of people who are very, very loud leaders and lead loudly, which isn't necessarily my style. And I really, really admire the way she has just made such a powerful impact in this space. I can't share with this you publicly, but I recently was CC'd on an email that Mariana had actually organized around social media activities, and I was looking at it, and I was like, "Oh my gosh, this is like unreal level of team organization skills, communication skills." So it's really, really cool to celebrate you yet again, Mariana, with co-discussing here. I'll hand the mic to you for you to say hello, and then we'll introduce our case presenter at the end.
Hello, everyone. I am Mariana. I am an international medical graduate from Brazil. I'm applying to internal medicine residency this season. I'm very glad to be here, and I'm very glad to hear this kind introduction as always. Thank you very much, Rabih. Thank you very much for creating this space for us to learn and to grow every single day. I'm very, very grateful for that. And I am very excited about this case.
You have a lot of reason to be excited because we have Patricia who's presenting. And I don't know if you remember Patricia's last case. It was quite the whirlwind, learned a lot from it. So, Patricia, I hand the mic to you to say hello, tell us what's new in your life, and then whenever you're ready, jump into your case.
Hi, everyone, and thank you for the introduction. I'm Patricia from Cameroon. What's new for me? Nothing much, I'll say. I'm just working at the hospital, waiting for the result. I like try to putting my rank order list in order, as an applicant. I think, and just try to relax and, enjoy enjoy the free time I have left, I hope. So yeah, that's about me. Thank you.
I've never wished a little free time upon anybody, but I wish it for you and for your sake because I think you're going to be an outstanding resident physician, hopefully in the near future.
Thank
Yeah,
you.
no, for sure. All right, Noreen, we're ready for you to share your screen whenever you are, and we'll jump right into this case.
Okay. Okay, so I have 6 aliquot for you guys. The last aliquot will reveal the diagnosis. On the first aliquot, it's important that I give you the setting. So you are in an emergency room in a public hospital, and a patient of 70 years old is 70 years old man is referred to your structure for a severe anemia at 4.5 gram per deciliter.
Fascinating. Patricia, I think your video is frozen, so I can't tell if you want us to stop here or whether you're frozen. Do you want to just say out loud? Huh. I guess, Mariana, we have no choice but to stop here, which is awesome, I think. What I got so far is that we're dealing with severe anemia of hemoglobin 4.5, I believe. I thought it was a 17-year-old, but I'm not sure if Patricia said 70. But what are you thinking so far?
So first of all, when I think about anemia, and we have discussed this a lot in the academy sessions, acute anemia, we have to think about bleeding and hemolysis because you have to think about loss of blood. So the first thing for me would be um, to investigate like any source of bleeding, especially GI and GU bleeding. Um, and after that, I also would be concerned about any type of hemolysis, but I think bleeding is the most important here. So I would be curious to know if this patient has had any bleeding in the past. I also would be interested about associated symptoms because if the patient has like, for example, nausea and vomiting, I would be concerned about something in the GI tract. And if we don't have like any source of bleeding, if we don't have hemolysis, I would be thinking about a chronic anemia and um, maybe malabsorption or something like that. But for now, I'm thinking about bleeding.
I love your sheer inability to think past the most life-threatening things. And I think what you did there is you made the correct assumption that unless you know otherwise, you should assume it's acute. And the differential diagnosis of acute isolated anemia is very narrow. And then you said bleeding is more deadly than hemolysis in general. And so I'm going to think about bleeding and then bleeding where? And the most common is GI and GYN. I love that. Um, One thing for us to try to do is to humbly acknowledge we don't know the time course, but to make an educated guess. So based on the hemoglobin of 4.5, is your instinct telling you this is more likely to be acute or more likely to be chronic? What do you think?
I think it's more likely to be chronic because um, it seems like it has been happening for a while now because it's too low. Um, And I imagine that patients, for example, if they had a normal hemoglobin and they started to bleed, they would have symptoms like much earlier than a 4.5. So I would say that this is chronic.
Exactly right. For a patient to present to the emergency room with a hemoglobin of 4.5, if they were truly bleeding, it would be a code blue. And the fact that they are able to show up to the emergency room means they've had time to adjust to this very harsh reality that they have. Um, just like Rahul in the snow, they've had time to put gloves on, get a little coat, get cozy. This wasn't just boom, minus 23 degrees exposure, right? There's been some adaptation here. And so I agree with you. I think you're probably going to be saying that this is more subacute chronic anemia. And in that space, I remember you actually articulated it in the academy session then, but I'm curious if you were to assume it's chronic and try to make educated guesses, what pieces of information is your mind hoping to know sooner rather than later so you can make progress?
Um, so assuming this is chronic, I would be interested in knowing this patient's ferritin and also transferrin. So I would be thinking in an iron deficient anemia first, but also we can't rule out um, chronic bleeding in this case. So I would be still worried about chronic bleeding in the GI, in the GUN, and we also discussed bleeding in the lungs that can happen like in a chronic uh, period. And other than that, I would think mainly in these iron deficient anemia, chronic bleedings, and mm, malabsorption. We still can't rule out that, but I don't think it would appear with a hemoglobin of 4.5. I'm not sure about that, but it seems like too severe for a malabsorption for me.
Yeah, I agree. I think that what you're saying fundamentally is that a chronic anemia, the most common causes worldwide are chronic versions of acute diseases. So it's not acute blood loss anemia, it's slow bleeding causing iron deficiency. It's not an acute hemolytic crisis from a microangiopathic hemolytic anemia, it's chronic sickle cell disease. And so I think that should be the first gaze in a patient with a chronic anemia is to make sure that they don't have a slow version of something that could present acutely. I love that. And so with those things in mind, I think we can hand the mic back to Patricia to give us the HPI, but maybe clarify just if the patient is 70 or 17 years old. That might help us in the future. Mike,
7-0.
70. Okay.
Hi, thank you. Okay, I love the discussion, acute or chronic anemia. Okay, when we receive the patient, we receive those exams already. But when you get the chance to see the patient and get the history, the family tell you that the symptoms started a week ago with fatigue, confused speech, restlessness, and sudden motor deficit of the right upper limb. They went to a structure where they took his blood pressure and the blood pressure was elevated in grade 3. You don't have the exact number, you just know that it was elevated. And they did preliminary exam as the CBC, where you got the 4.5. Then the patient is referred to you. You ask more questions and they tell you that the patient, he did not have any diarrhea, he did not have any hematochezia, no melena, no headache, no vomiting, no anorexia. Or I will stop there.
Oh my gosh, wow, what a twist. Mariana, what are you thinking with this information?
So I started to think about our missed mnemonic for confusion and altered mental status. I don't know exactly if it's the case here because it's more like confusion, um, but it can give us something to start. So if you have this patient has any like neurological condition, so I would think about metabolic causes. I would think about maybe some infections or stroke or toxins. But considering that this patient has an hemoglobin of 4.5, I would be very concerned about intracranial bleeding that could be associated with these symptoms. Um, and this is the main way for me to connect low hemoglobin with um, neurological symptoms, especially considering these motor deficit in the upper limb. However, it happened 1 week ago. I'm wondering if this patient has been bleeding for this time or if uh, these like the symptoms are not connected. Yeah, that's what I'm thinking right now.
Yeah, no, I completely agree with you. I think that when you receive that hemoglobin of 4.5 and the patient is hypertensive, you can immediately come to the conclusion that the patient's not having acute blood loss at this time. And I think it makes it very unlikely that in the absence of visible jaundice, because hemolysis, the other cause of acute anemia, required, if the degree of hemolysis, remember when the academy session, we talked about how a degree of hemolysis, it determines the degree of the clearance mechanisms, including the bilirubin. So if you're somebody hemolyzing to 4.5 without some visible jaundice, it's pretty unusual. So you can start to say, I'm not sure this anemia is acute. And so then you're stuck with, okay, well, this anemia is at least subacute. How can I merge it with the history that I'm here, but that is a little bit more abrupt in onset? And I think what you probably ought to do is to say, okay, I'm going to use the anemia as a clue to understand what's going on. And it certainly explains the fatigue, but the anemia itself doesn't explain the confusion and the right-sided motor deficit. And so I think you would probably be able to you probably have to wonder, let me put the anemia to a side for one moment and try to explain, as you did, the confusion, the speech issues, and the motor deficit. And so, as you said, you're worried based on these findings, you're most worried about a stroke. And the question is it a hemorrhagic stroke or an ischemic stroke? And I think that as you said, the more likely scenario is that somebody doesn't lose enough blood in their brain to become anemic. It might mean that there's an issue with the blood itself that is causing it to clot. So based on the fact that we are worried about an issue in the blood, i.e. anemia, and the patient develops a focal neurological deficit, I think it's reasonable to proceed down the pathway of, now we have two problems in the blood: anemia, which has been proven, and possible thrombosis in the blood. And that hypothetical concern would make me worry significantly that there's about to be more and more catastrophes. And the truth is, when somebody has sudden motor deficit, raising concern for a stroke, the fact that they're also confused would be unusual and does, in fact, increase the possibility that they have an intracranial hemorrhage, which is caused by the mass effect. But the hypothesis that's more consistent with the anemia would be that they actually have a focal large stroke, but also small occlusions in other places that are causing them to be confused. So like you, Mariana, I'm pretty worried about this patient because they have a devastating and severe neurological deficit. And the priority should be to evaluate for stroke, ischemic or hemorrhagic. But the long-standing subacute nature of the anemia is much more in keeping with a thrombotic issue than a hemorrhagic issue. But like you, we have to proceed forward fairly quickly to make sure this person doesn't lose their brain function as a result of this process. All right, Patricia, mic to you.
Amazing thoughts. Okay. For the past medical history, you gather that the patient suffered from rheumatism. He doesn't have any history of hypertension, no history of diabetes. Social history, the patient lives in Cameroon. He does not smoke. He does not consume alcohol. The vital sign when you receive the patient, his blood pressure is at 191/88. The heart rate is at 19 beats per minute. He's tachycardic. His temperature is at 39 degrees. His saturation is at 94%. And he has a glycemia of 5.75. Physical exam, the patient, when you look at him, he appears confused, he's weak and fatigued. He has pink conjunctiva, but he also has some sign of jaundice. Cardiovascular system is regular, is tachycardic, no murmur, no gallop. Pulmonary system is clear, no abnormal sound. The abdomen is soft, non-distended, and there is no masses, there is no palpable masses. The abdomen there is a diffuse tenderness when you palpate the abdomen. Neuro exam, he has like a motor deficit of the right side. Muscular force is estimated at 4/5, and but sensation are intact. MSK, you notice some petechiae on the lower extremity and the abdomen. Rectal exam, he does not come with any blood, but fecaloma. I'll stop here.
Oh my gosh, Patricia, this problem list is increasing so much. We have a fever, we have tachycardia, we have petechiae, we have a motor deficit. Mariana, where is your mind inclined to start? There's a lot of information here.
Yes. So something that caught my attention is that this patient does not have a history of hypertension and is appearing with very elevated blood pressure. And so for me, this is one of the ways to start to think about it. And also the petechia, it also shows that we may have a coagulation problem as you anticipated, Rabih. Um, so I'm thinking if we should try to put everything together, or we should assess any like the problems by themselves. Something that came to my mind is this pressure, blood pressure, this high blood pressure causing hemolysis in some way, because we could connect everything this way. Maybe this patient has encephalopathy due to the high blood pressure and also hemolysis because of the high blood pressure. But what is causing this high blood pressure? So I definitely need your help here.
Yeah, I I feel like we need each other's help, Mariana, because I think there's a lot going on in this case. I think that you'll find when you see more and more patients that blood pressure like this is often a consequence of so many things that are going on rather than the core issue of the case. Many patients, when they're uncomfortable or in pain, can elevate their blood pressure, and nobody comes to the emergency room without some form of discomfort or some form of pain. However, there are two instances where paying importance to the blood pressure can help you tremendously diagnostically. And that's when you have neurological diseases or kidney diseases. Because if you're hypertensive and you have a kidney disease, you should really worry about a glomerular or vascular problem. And if you're hypertensive and have a neurological condition, you really should worry about another vascular problem, which is ischemic or hemorrhagic stroke. So the only reason I would be paying attention to the blood pressure here, I think, is because the patient is presenting with a neurological syndrome that has me worried about the vasculature. So in simple terms, hypertension, acute hypertension in a hospitalized patient is often noise from increased catecholamines from discomfort. But less commonly, it can be a clue to a vascular disorder, either in the kidney or in the brain. And because we're entertaining a possibility of a vascular disorder in the brain, I think I would pay attention to it, because it, of course, is a diagnostic clue, but also it's management and maintaining normal cerebral perfusion is important to not worsen the hemorrhage or induce a hemorrhage in somebody with ischemic stroke. I love that you picked up on the jaundice, and in the context of anemia, are saying, hey, could this person be hemolyzing? And I think that the combination of jaundice and anemia is certainly evocative of hemolysis, but unfortunately, the prevalence of hemolysis and liver disease is also another thing that we have to hold back in our mind. So you have to take the jaundice and prove it's indirect hyperbilirubinemia before you latch on to hemolysis, because it easily could be the patient has chronic liver disease, is jaundiced, and is also anemic. So I think that we'll have to put in our back pockets. What I was most intrigued by is your thoughts on the fact that the temperature is 39 degrees Celsius. What did your mind do with that?
Yeah, so Definitely, I'm thinking about an inflammation happening, and then we have to start to think about the source of this inflammation. Um, I would be very concerned about infections. And then we have to start to think about infections that may appear with decreased hemoglobin, and maybe we don't know the level of the platelets yet, but we can have like increased or decreased. So uh, like the initial workup will help us to think about what types of infections we are dealing with. Um, and if I'm thinking about an infection, how I'm trying to connect the neurological symptoms with this infection, especially because this patient has a focal deficit in the right upper limb. Yeah, so I'm trying to connect the dots, but I don't know exactly how to make progress here. I think the CBC will be very important so we can have a better idea of what we're dealing with. But I struggle when I have to connect like infection with the neurological symptom, if like the neurological symptom is part of the syndrome or is a consequence of that.
Yeah. I mean, certainly this is not a situation that you'll see quite frequently in the US, though you may see it in some parts of the world. And I think if you take a simplistic approach, Mariana, and you say, yeah, it's uncommon to connect fever and a focal neurological deficit, but you may take the simple leap that the thing that's occluding the blood vessels is actually pus. And the reason the patient has both a fever and a stroke-like syndrome is the process that's causing the stroke-like syndrome is an infection in the blood. And the most common infection in the blood that you'll see in the United States is endocarditis. And so the combination of a stroke with inflammation makes you think, okay, there's pus, and you might consider in the United States empirically treating for endocarditis. But the pus does not have to be macroscopic, i.e. the bacteria floating between cells. You can also have an infection inside the cells, i.e. microscopic infections that don't grow on blood cultures. So if you were to think of what to do, you might think, okay, macroscopic infection visible on cultures, endocarditis, but microscopic infections that live inside the white blood cells, red blood cells, macrophages. And so when you take that thought process and you layer on that this patient is in Cameroon, what infections come to your mind that could potentially do this?
I would think about malaria because malaria can appear with this high fever.
Yeah.
Um, and if we think about like organisms that can be inside the blood, I also think about Babesia, but I don't think Babesia is very prevalent in Cameroon, and I'm not sure if it would have like a severe presentation like that. Yeah, I also would need your help here.
Yeah, no, I agree. I think malaria is the most important organism to think about here. And so if you were keeping some treatments right next to you, either giving them to the patient or preparing to give them, you would consider in this patient antibiotics for endocarditis, which in the United States would be vancomycin and ceftriaxone. And you would be considering to give a treatment for anti-malaria, which I'm not an expert at, so I can't make any specific leaps on what to give this patient, but that's probably what I'd be looking up. Of course, you don't have to have an infectious cause of fever and thrombosis. You can have an inflammatory condition that does so. And I think that paying attention to that parallel thought is going to be very, very key. Mariana, when you are thinking, you haven't proven, when you're thinking of hemolysis and stroke, what diagnoses exist in that non-infectious inflammatory state of hemolysis plus stroke?
Hemolysis plus stroke. I I I would say I don't maybe MAHA would cause hemolysis and stroke, and also I'm not sure about DIC. DIC,
Yeah.
I don't think DIC is real would cause stroke, right? It would be more MAHA and DTP also.
Yeah. Yeah. MAHA, the DIC and TTP are both examples of a microangiopathic hemolytic anemia. And the most common presentation of microangiopathic hemolytic anemia is microthromboses. So small, tiny thromboses, not macro thromboses. So if you ask yourself, how can a MAHA cause a macro thrombosis? The most common cause is TTP. It is possible in DIC for sure. It is possible in antiphospholipid antibody syndrome. It is possible in a cancer-associated MAHA. But if you're asking yourself what MAHA is most apt to causing a thrombosis big enough to occlude a vessel big enough to cause a deficit this big, it would be TTP. So for me, I think that I would be I will tell you that the peripheral smear and a smear pathologist is the most important person in this hospital right now. Because looking to see if there's malaria, looking to see if there's cysticytes is going to be very key. But we cannot proceed with all the assumptions we're making. We're assuming this is an ischemic event, which we don't know yet. We're assuming this is hemolysis, which we don't know yet. But this is why I'm having a longer conversation with you here, is to really show all of you that you have to make assumptions sometimes to treat the patient who could die before you confirm your suspicions or could disprove your suspicions. So we're making a lot of assumptions only because these assumptions could be compatible with this patient and the patient could have serious consequences before we prove them. That's what empiric therapy is about. But the mistake that tends to happen is either you don't make assumptions because you don't want to make any assumptions, you want to wait, and the patient suffers as a result. Or more commonly, what you do is you forget that you've made assumptions and you stay focused and assume that the assumptions you made are in fact truths. So we just generated some life-threatening hypotheses to start treatment. But now I think, as you said, we have to disentangle ourselves and say, this is a inflammatory syndrome in a patient presenting with focal neurological deficits and anemia, jaundice, and possibly a bleeding diathesis. And we'll see where those facts take us. And so for that, I'll hand the mic to Patricia to tell us more.
Amazing. Exactly, we had the same thought. You know, when you receive a patient like that who has like a lot of comorbidities, you need to pick the most like you think which one is going to kill him first. Like in our head, when we received the patient, it was like, okay, we need to eliminate, like to put a ischemic event on the side. So before even take the blood for the CBC, we just direct the patient to a head CT. So and the next aliquot you receive is what the head CT show. So the head CT just show a recent ischemia in the brainstem. That's what we have relevant here. And after he was done with the CT, we tried to stabilize him. The glycemia was really elevated, so we tried to correct the glycemia, control the blood pressure by putting him on Roxanne, and give him some blood because he was anemic, so we had to give him blood. Then we started to think more about what it might be. Then we look at, for the CBC, we had a white blood count. No, yes, the white blood count was elevated at 21,580, and with a neutrophilic count of 700 and a lymphocytic count of 1,010. Hemoglobin, as you know, is at 4.5, with the MCV at 87, and the reticulocyte count is elevated. Platelet is at 12,000. BMP, we have the natremia was normal, 143.3. Kalimia was also normal, 3.56. Chloride was normal, and the HbA1c was at 12%. I'll stop here.
Patricia, can I just clarify one thing? Do you mind saying the
Sure.
white blood cell count one more time?
21,580.
21,000. Okay. And what was it mostly neutrophilic or what was the predominant cell type?
The predominant cell type, like the neutrophilic was at 700, so it was neutropenic, and the lymphocyte was at 1,010. It was still low, but it was the most elevated in the count.
Okay. So he has mostly lymphocytes
Mhm.
and are there so if he has 21,000 total and only 1,000 lymphocytes, is that right? Or am
Yes.
I see. And so
Yeah.
do we know yet what is accounting for the other 19,000 cells he has, or is that unknown?
Is unknown. That's a good question. It's unknown.
Okay. All right. The mystery deepens. Um, so Mariana, what are you thinking?
Um, so the first thing that I'm thinking is that the platelet is very, very low. And it explains the petechiae. And now we have anemia and thrombocytopenia and leukocytosis. So
Mhm,
this kind of frames better the picture that we are
mhm.
um, discussing here. And also this ischemia in the brainstem. Um, I'm not sure what I can do with that, Ravi. I need your help.
Yeah, I think. Oh no, sorry, you were going to say something else. Sorry.
No, I'm just trying to think about anemia and associated with thrombocytopenia and what I can do with that, especially regarding the infections. I'm not sure if malaria would have these characteristics and also these different white blood count, differentiation. I'm not sure if malaria would have these characteristics.
Yeah, I think it's a very good exercise to ask yourself, what progress can you make when you have an anemia and thrombocytopenia? And I think that, of course, the more cell lines you have involved, the more and more likely you are to have a um, issue in the bone marrow. But you have to think of ways that you can destroy both red blood cells and platelets in the periphery. And the way you can do that is you have a vascular problem like a MAHA that destroys both of them. You have an antibody that destroys both of them, autoimmune hemolytic anemia and autoimmune thrombocytopenia. Or you have an infection that goes inside both cells like malaria and babesia. So the simplistic approach to the combination of anemia and thrombocytopenia recognizes that the more cells you have, the more likely you are to end up in the bone marrow. But that a simple process that can tag both of them at the same time is a vascular process like TTP, an antibody, or an infection. And so I think you have to proceed with ruling out the infection and the antibody first. Infection and the vascular first. Antibody-mediated disease is the least morbid compared to malaria and TTP. And so the question is, well, what can you do with the white blood cell count? And the white blood cell count here is tricky because there's a little bit of a knowledge gap on my end. If the white blood cell count is 21,000 and there are only 1,700 cells accounted for with the lymphocytes and neutrophils, that leaves us a large gap of unaccounted for white blood cells, which would likely mean that they are blasts, which would put us in the bone marrow. If, however, the white count is not elevated and that there are no mystery cells, then I think that there's no reason to rush to the bone marrow. So I think it goes to show you how key knowing the whole CBC is accurately And the reason I'm inclined to lean away from a bone marrow problem is the fact that the patient has elevated reticulocyte count, implying that the bone marrow seems to be healthy. So I'm not sure what to do. I feel for Patricia and the dilemma here, because on one sense, there are 20,000 unaccounted for white blood cells, and you should never have a single one that's unaccounted for. But at the same time, you see that the bone marrow is healthy. So I would probably just call the hematology lab and be like, hello, good morning, how are you? And just see if they're frazzled or busy or, panicking. But I think analyzing that is going to be really, really key, because it'll help you say, okay, I'll stay in the peripheral destruction part, because the CBC, oh, I talked to them and they explained to me what the issue is, and I'm happy with it. I'm satisfied with their explanation. In which case I trust the retic count. But if the hematology lab says, yeah, I don't know what these cells are, then I would cast doubt on the validity of the reticulocyte count. I think the indirect bilirubin will be helpful here to see if this person has hemolysis. And I think that your question about the stroke is a really important one, because ultimately when you have a stroke, Aaron talked about how to think about a stroke. Is it an issue with the pump? Is it an issue with the pipe? Or is it an issue with the plasma? Examples being atrial fibrillation, carotid atherosclerosis, and then finally TTP. This is almost certainly a plasma-mediated stroke because of how many issues there are in the plasma and how busy the hematology lab is from having to give us all these very scary numbers. So I think the stroke mechanistically is very simple. It's not unlikely to be the pump, unlikely to be the pipe, very likely to be the plasma. And so all our efforts here have to be directed towards understanding the plasma. And I think the best way to understand the plasma is a peripheral smear, which will either show blasts or schistocytes or malaria. And I think that the peripheral smear is the really, really key test here. Alrighty, Patricia. Oh, sorry, Mariana, did you have something else to say?
It's just a question for you because so we are relying on the blood smear, but we have an hemoglobin of 4.5, and I'm just thinking about the sensitivity of the exam, considering that we have like a low number of red cells to look into. So yeah, it's just like a practical question. When you have like a low hemoglobin like that, is it blood smear very helpful in this situation too, or you have to be cautious with that?
Very good question. I think that your question also emphasizes the importance of getting the smear before you give blood, because what you will do if you give a lot of blood is you will just do a peripheral smear of the bag you just transfused rather than the patient. But the truth is that the deeper the anemia is, the more sensitive the smear is, because the more damaged and dysfunctional the red blood cells is, the more likely you are to see the fingerprint of the disease. So for example, in patients who have a microangiopathic hemolytic anemia, the amount of schistocytes will increase dramatically with the degree of hemolysis. So it's actually very hard to try to make a diagnosis of somebody who has low-grade anemia on the peripheral smear 11, 12, 13. The probability of seeing probability of seeing something abnormal correlates with the amount of normal left. And now that there's such little normal left, the peripheral smear is likely to be abundantly filled with all the abnormal findings. So the most important person in this hospital is the person with the microscope, I think. And even if they tell us that actually, oh, they didn't find anything, that'll help so much. If they don't find malaria, the degree of parasitemia required to do this is high. It's not going to be subtle. If they don't find schistocytes, they don't find blasts. So a negative smear here will be enormously helpful. All right, Patricia, mic is yours.
Okay. Okay, more exam. We have the liver function test. The AST was at 34.6. ALT was at 23.76. You guys asked the bilirubin. The conjugated one was at 11.4, which was elevated. and the total bilirubin was at 30.85, which was also elevated. Renal function, creatinine was at 23.46, and the BUN was at 0.36, which was also elevated. You asked for the peripheral blood smear. It did not show any malaria, but it shows some schistocytes. I'll stop here.
Patricia, I just want to commend you for such an incredible presentation, because I know you could have given us the peripheral smear earlier, but you really allowed us to get study this ischemic stroke, study the jaundice, the anemia, and really make Mariana have to use every ounce of caffeine that she consumed this morning. But now I think we have some momentum, Mariana. So I think for people who are maybe new to this VMR space, this case might be a little bit overwhelming with how complicated it is. So maybe you can just do them a service by summarizing this case so far and what your working problem representation is, so we bring them all up to speed.
Yes, so we have a 70-year-old male that presented to the emergency department with fatigue, confused speech. He was found to have an hemoglobin of 4.5. And in the physical exam, he was found to have high level fever of 39 Celsius degrees, a high blood pressure, tachycardia, jaundice, and also motor deficit on the right side. And the CBC showed anemia combined with thrombocytopenia and leukocytosis. And we also have an increased creatinine, increased total bilirubin, and schistocyte in the peripheral smear. So with that, I feel that we completed the TTP unnecessary abnormalities here, because we have like increased creatinine, we have increased bilirubin, we have altered mental status, and fever. So, and especially because malaria was not found in the peripheral smear. So I think we are leaning towards TTP at this moment. What else can I say about? Oh, and when Patricia first told us about the conjugated bilirubin that it was increased, I started thinking, oh my God, we have to shift towards something cholestatic now. But when we see that the total bilirubin is increased, and we also have like an increased indirect bilirubin, it makes a lot of sense that the conjugated is also increased. So yeah, that's what I'm thinking about now. And with that in mind, I also think that we have to start shifting our treatment. We have to start this patient on corticosteroids. And yeah, what do you think, Rabih?
I'm right there with you, Mariana. I think that I have nothing to add to your thinking. I'm also worried about TTP significantly. What is your understanding of the pathophysiology of TTP?
So please correct if I'm wrong. But from what I remember in TTP, you have I'm not sure if you have a problem with the Adam S13 protein, and because of that, you have like it starts to consume platelets, and because of that, you start to have like a lot of small thrombus, and this can cause like the ischemia in the brain, but also ischemia in other places. This is what I remember.
Yeah, exactly right. So there's an enzyme called Adams TS13 that circulates in our blood, and that enzyme cuts hair. Now, what do I mean by that? Our blood vessels, they have hair that goes on the inside, and that hair is von Willebrand's factor, and that hair is meant to trap and coagulate. And so our hair is much longer than it needs to be, and Adams TS13 trims that hair. TTP in 90% of patients is an antibody to Adams TS13 that causes that enzyme to no longer function. And so as a result, we are left with very long hair. And what that does is it triggers the coagulation cascade. And this happens in every single blood vessel in our body, but it tends to disproportionately affect the neurovascular blood vessels. And so what happens is the first thing that the ADAMTS-TS13 binds to the platelets. The long uncleaved von Willebrand's factor binds to the platelets, causing thrombocytopenia. You might ask, okay, well, why is there hemolysis? Eventually, when you have so much platelets that are clumped, crowding your blood vessels, it creates a very turbulent area of flow. And just like the hose, at the end of the hose, the more and more you occlude it, the more and more turbulent and the more force the water comes out. And so then the red blood cells are destroyed by sheer force alone. And only after that has happened do you have complete occlusion of the blood vessel to the point where you develop a stroke. So I want you to visualize the first thing that's happening is a deficiency in ADAMTS-TS13 activity that causes platelets to be low. The lack of thrombocytopenia is a decent but not perfect argument against TTP. Hemolysis and hemolytic anemia then ensues, and only after severe hemolysis really do you ever get a macrothrombosis, enough to occlude the whole lumen. So platelets are always going to be low, with few exceptions, then the hemolysis, then the macro occlusion. So in the United States, you will almost never see this. And when you do your training here, Mariana and Patricia, you will learn that the pentad of TTP is exceedingly rare because the fever and the macrothrombosis are such late manifestations that they represent untreated, uncontrolled disease, often for weeks. And so for me, this is a profound presentation. I've never seen TTP like this, assuming it's TTP, but you should assume it until proven otherwise. And I want to emphasize that the fever here is extremely unusual. And the neutrophilia here, or the leukocytosis here, is extremely unusual. So much so that you should cast doubt on the diagnosis of TTP when somebody is this inflamed from it and has an overt thrombosis from it. The vast majority of TTP only occurs with hemolytic anemia, thrombocytopenia, and schistocytes. And that's when we want to diagnose TTP, before the patient gets so inflamed and so occluded. And so the fact that this patient is inflamed and occluded should do two things. It should cast doubt on the diagnosis because the patient's so sick, but it should force us to treat the patient with tremendous ferocity. So what would happen if you have all the resources available to you? You need to get that antibody out. So you do plasma pheresis, get it out. But you also, at the same time, want to give this patient more ADAMTS-TS13. So this is why you don't do plasma pheresis, you do plasma exchange, which takes the patient's plasma, throws it in the trash, and gives the patient fresh plasma, which doesn't have the antibody and also has the new enzyme. You give the patient corticosteroids, and the beauty about TTP is you can confirm the diagnosis in two ways. The patient should get better very quickly with you doing this because the problem is solved with plasma exchange. And so improvement with treatment is a powerful diagnostic test, but the thing that confirms it is the ADAMTS-TS13 activity. Now, here's where you have to be very careful. An ADAMTS-TS13 activity that's low is not sufficient. It needs to be almost undetectably low to cause such a severe syndrome. So an activity of less than 10% is a core diagnostic feature. Just because it's 11 or 15 or 20, you have to be careful. So the diagnosis is confirmed when the patient ultimately gets improvement and ADAMTS-TS13. Both are required. you also, in all patients, should look for two underlying diseases. Mariana, do you happen to know any disease associations with TTP?
Not from the top of my mind. I probably knew this at some point, but if I had to guess, I would say that some types of malignancy may be associated with DTP or autoimmune conditions.
Autoimmune is correct. Lupus is the most common association, but unfortunately also HIV. So also should think about testing for HIV in all patients with TTP, but also consider to see if the patient has other features of lupus like glomerulonephritis, rash, so on and so forth. All right, Patricia, I would love if you told us this is not TTP, this is something else. I would learn so much more, but we'll hand the mic to you to tell us what happened.
No, this is our last aliquot. Okay, so we gather more imaging. We gather an abdominal ultrasound that's just so homogeneous hepatomegaly and splenomegaly. And the TAP scan, the TAP CT also we ask for it because we are also confused about his glycemia, like hyperglycemia for a 70 years old man who did not know that he have any history of diabetes. He showed with a H1, which a HbA1c of 12%. So we asked for the TAP CT, which show nothing, no adenopathy, just the hepatomegaly and the splenomegaly. So as you guys, we concluded with the confusion, AKI, anemia, and thrombocytopenia. We concluded at a acquired thrombotic thrombocytopenic purpura TTP. Unfortunately, we couldn't do the Adams 13 test, unfortunately. That would have been so cool. But we gave we cannot do plasma exchange or plasma we have plasma exchange. We couldn't do that. We just gave high dose of corticosteroid. Like we gave them like the two first day. Yes, the two first day. And the patient did not improve much, but it was less confused. It was less confused. That solidified our diagnostic of TTP. I will stop here, hear from you guys, and then give you like what happened later. But this is our diagnostic TTP.
Yeah, Mariana, what do you think?
Yeah, thank you very much for bringing this case. I learned so much and it was a very educational and a fantastic case in general. So thank you very much for bringing this case. And yeah, a lot of things to read and to review and to be more prepared for next time. But it was awesome. Um, and so just to clarify, this is the final diagnosis, right?
Yeah.
Okay, yes. So yeah, that's basically what I have to say. Thank you very much.
Yeah, I'll hand the mic to you, Patricia, just to finish us up, and I'll share my reflections when you're done.
Okay, so after 2 days, unfortunately, our patient he started developing hyperventilation and hypersedation, and we could not stabilize him. We assumed that maybe since he had like an ischemic stroke in the brainstem that was controlling the breathing and other stuff, maybe that's why he could not, like he started hyperventilating and the hypersedation. So maybe after 2 days, 3 days, he just passed away, and yeah, that was it.
Yeah, a very, very tragic case for a condition that I think is very, very deadly. And Patricia, this is one of my favorite parts of a virtual morning report, is it really gives us a global perspective on diseases. And I think all too often our illness scripts are very geographically constrained. And I think here you're, I think, sharing with us what full-blown TTP looks like, which many people will never see. And I think I can only imagine the challenge of trying to slow down such a ferocious monster with less tools in your pocket than you have learned about. And so I'm really curious just to ask you how it felt for you to take care of this patient and what lessons you took from this experience. Oh, I see she's frozen. Uh-oh. Let's see if she's able to come back. Yeah, I think unfortunately Patricia seems to have frozen. Mariana, I'm really curious. I know I say this because I know you actually just gave us a very powerful academy reflection on global health perspectives and resource limited areas. I'm curious how that element of this case is landing with you.
Yeah, as we discussed it in this weekend Academy VMR, I'm always wondering if this patient would have another like would have different opportunities and maybe a different treatment and maybe would have more chances to survive if it was a different setting. This is always something that comes to my mind, but yeah, this is one of the questions that I have for you. What is the prognosis of a patient like that are not able to receive like plasmapheresis or and the other treatment? But I think it's very unfortunate in general because as we discussed, the problems like with global health and health systems in general, they're much bigger than we are. And what we can do is just reflect on that and bring like all and learn from these cases.
Mhm.
And I think that's the best way to honor these patients.
Very, very well said. I see Patricia is back. Yeah, Patricia, we're really curious what it was like for you to take care of such a complicated, tricky, and aggressive disease. What did it feel like? Oh no, I think we lost her again. Oh, poor Patricia. Yeah, I'll just share with you, Mariana, that I think it is very heartbreaking to see how this patient's outcome might have been very different. But at the same time, I think, um, resources are asymmetrically distributed in the world now, and they have been for the history of humanity. And I think that what's really powerful is to see that this was the state of affairs, this disease and the way it was presented and the way it was managed. It was the state of affairs not too long ago. We're talking less than 100 years where this condition, TTP, has probably afflicted people for the entirety of humanity. And in less than 100 years, less than a few decades, we've taken a disease with 100% mortality and reduced the mortality to 80%, by 80%, sorry, to less than 20%. So it's remarkable what progress has been made to address this condition, and that hopefully the more symmetric distribution of resources will eventually mean that everyone everywhere in the world will have a better outcome with TTP. But at this time, I think we live with the sad reality that and the knowledge that this patient probably would have uh, been had a better probably had a better outcome in many, many parts of the world. But that I think stands in powerful contradistinction to the most important thing that all of you are doing here and on YouTube, which is that, geez, if you had no idea this was TTP, then you wouldn't know what you're doing, or you wouldn't even know what the patient's mortality is. And so that's what we ended up talking about, is just the sheer power of clinical reasoning and to be able to make the most of your resources. And that's fundamentally what clinical reasoning is to be able to get as much juice out of the information that you have, to be able to inform and arm your patient with the most knowledge. And so I think I wish I could see Patricia, but I wanted to commend her on the ability to actually make this diagnosis of TTP is incredibly hard when you don't have the resources of the ADAMS TS13 and everything at your hand. And I admire her so much for her resilience to push through the barriers that she faced with this patient, to not only deliver them care, but to also share this learning with us. It's really, really remarkable. I see her back now. I don't know if we can hand her the mic. But yeah, Patricia, go for it.
Okay, thank you so much for hearing my case and for this great discussion and for this compassion too. That's one of the reasons I also love this space. And you are great, like that's correct. Here in some part of the world we don't have like the same resources. And yeah, healthcare can be difficult to access to, because even if you do have the resources, like, but it can be really expensive. Like the patient cannot afford it. And in this case, I learned so much, like not only how to take care of, like how to take care, not take care of reading simple diseases, like how to handle ischemia, hyperglycemia, hypertension, but even the diagnostics of TTP. Unfortunately, I'm not alone in my, I'm not working alone. I have an amazing team, and our internist too is a great doctor. So yeah, like the fact that we are able to sit down and think and read and try to to look what's best for our patient and do what's best for him. It's unfortunate that we couldn't do more, but we learn a lot. I I learned so much from this case and from this discussion too. The way also you approached it, it was amazing. Thank you so much. Thank you for this space.
Yeah, the feeling is mutual, Patricia. Thank you. All right, I will hand the mic to Rahul. And Rahul, I will give you a new challenge. You've captured literally everything we talked about. I was reviewing your teaching points now. I'd love for you to emphasize what your top 3 teaching points were, just for the sake of time.
Absolutely, Ravi. Thank you so much, Patricia, for bringing this amazing case. So, if I were to choose three major points here, I would always think of uh, here's a Ravi really demonstrate a good nuance here, because this patient came to the ER with the presence of hemoglobin of 4.5. Now, is this something, if the bleeding is really acute, he's gonna code. But the patient presented to the ER, it means the patient is having some time, and maybe you could think of a subacute to chronic course of anemia. And the other thing, recently we had a discussion on acute hemolysis versus chronic hemolysis, and I really want to emphasize here. And what are the footprints of acute hemolysis? Elevated bilirubin, high LDH, and low haptoglobin. And in contrast, the footprints of chronic hemolysis would be high reticulocyte count and the extramedullary issues like hepatosplenomegaly and something like that. And the other thing, and it's very hard to choose, and the presence of acute hypertension in the hospital setting, mostly it would be noise because of the pain or catecholamine surge, but less commonly would be a vascular problem like glomerulonephritis. And in the context of fever, we could think of infections, inflammation, and CBC really helps in situation. But how can we connect the fever with focal neurological deficit? We can think of brain abscess or infective endocarditis. If your degree of suspicion is very high, we can get a blood culture, so you can start an empirical antibiotic therapy. And in the lastly, I would think of any microangiopathic hemolytic processes. It could lead to tiny thrombosis, a small thrombosis, and conditions like TTP, DIC, APLA, malignancy would really cause macrothrombosis. And in this situation, hematology and peripheral blood smear would really help us. And I really want to comment on the management part of the thrombotic thrombocytopenic purpura. And the management would be plasma exchange and giving the corticosteroids, and how to achieve the prognosis and how to confirm the diagnosis. It's usually two things. Is it improvement with the plasma exchange, or assessing the ADAM TS13 activity is less than 10? And what are the next steps once we have a cemented diagnosis of TTP? Would be assessing for HIV and lupus. So those are my teaching points. Thank you so much.
I knew you wouldn't be able to resist 7 for 3. David was counting. Incredible job, Rahul. Thank you for that clarity, and I love your enthusiasm. You would not, VMR would not be the same without the energy and love you interject into it. Thank you so much, Noreen, for scribing. I know today's case was very difficult to keep pace with. Thank you to Rahul for teaching points again, and a big fist bump to Patricia for an amazing case, and the same to Mariana for an outstanding discussion. I think Mariana will giggle at the idea that neuro cases will not escape. Every single time Mariana and I have discussed, there's always been neuro, but at least you got a lot more a lot more medicine this time. Thank you. Hi guys.